You are listening to the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat.
Hi everyone, and welcome to the October 2017 special Masters Edition of the PRS Journal Club podcast. My name's Chad Purnell. I'm PRS Resident Ambassador from Northwestern, and as always, I'm joined by my co-resident ambassadors, Shuja Shafqat from Fox Chase Cancer Center and Jordan Frey from NYU. Today we have the honor of being joined by Dr. Rod Rohrich, the editor of Plastic and Reconstructive Surgery and the professor and founding chairman of the Department of Plastic Surgery at the University of Texas Southwestern. Thank you very much, Dr. Rohrich, for joining us for this special Masters of Plastic Surgery edition of the PRS Journal Club podcast.
My pleasure and honor to do so.
So the article we'll be discussing next is Transparency in Functional Rhinoplasty, Benefits of Routine Prospective Outcome Measurements in a Tertiary Referral Center, from Drs. Datema, Van Zijl, Poel, Battenberg de Jong, and Lohuis from the Netherlands. Remember, all of this month's articles can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So just as a brief overview of this article, because I want to leave some good time for discussion, the authors note in the introduction that evaluation is important in rhinoplasty, but there's limited standardization of the evaluation that we do before we see a patient for a rhinoplasty consult. This article highlights the author's protocol in their practice, which is a university referral center with insurance paying for these procedures. For their methods, the authors prospectively evaluated patients who presented for a combined functional and aesthetic rhinoplasty at a tertiary referral center. Cosmetic patients alone were excluded, as well as septoplasty-only patients. And they used multiple different instruments prospectively. So they used the nasal obstruction symptom evaluation, or the NOSE scale, a visual analog scale for left or right obstruction, subjective body image and quality of life Utrecht questionnaire, and a visual analog scale for nasal appearance. And these respectively assess obstruction of the nose, the laterality of this obstruction, the patient's body image, the patient's quality of life, and then also their satisfaction with the overall aesthetics of their nose. They gave these to the patients pre-consultation and then at 3 and 12 months following the surgery. Of note, all of these outcome measures are patient-reported. The authors highlight that this system can be performed in only 5 minutes per visit, and they do this in the waiting room before they see the patients. They enrolled 269 patients in the study, and 171 of those patients that they saw were eligible for surgery, and 121 of those patients went on to have surgery. And so whenever they looked at these patients who all had 3 and then 12 months of follow-up, essentially every single one of these outcome measures significantly improved. I'm not going to go over the numbers just because literally every single outcome measure significantly improved for both revision and primary rhinoplasty patients. And this includes both the functional outcome assessments and the appearance assessments. However, in general, they noted that revision cases had less favorable outcomes overall compared to primary cases, but still significant improvements in all of the outcome measures in these revision cases. One of the interesting things that they show in their results is that they upload all of this data into a patient dashboard that allows both the physicians and the patients to look at this data with complete transparency and in a pretty granular fashion. And so in the discussion, the authors note that these are patient-reported outcomes and they're susceptible to some bias. And mainly they urge rhinoplasty surgeons to both prospectively evaluate their patients and also to standardize their outcome measures. This, in their mind, would serve to allow comparison to other surgeons and also to follow your own results with objective measures. And they note that following patients in a manner such as this may actually improve the learning curve with some of these types of procedures because you're getting more objective data as to how you're improving nasal obstruction and nasal aesthetics. In my opinion, what I thought of this paper was I thought this was a good study, and I also thought this was a good proof of concept. The authors clearly showed the benefits of using a prospective standardized set of outcome measures for every rhinoplasty. I think really that's true for every procedure. I think that every procedure can be made better by standardizing your preoperative and postoperative workup with standard outcome measures. I think the benefits of this are obvious, both for research and for following your own results. But I think what the authors maybe didn't necessarily do is they didn't really advocate for why their particular outcome measurements could be used versus any other outcome measurements. They definitely have fast outcome measures. They only take 5 minutes, and these give a good patient-reported set of outcomes. But there's also objective nasal airflow studies that can be used. And so that's one of the points I wanted to bring up a little bit later in the discussion. But overall, I think the lesson that I got out of this was follow your results and be critical and standardize whatever you're doing. So do the same workup for every patient. Just like everything else in medicine, if you do something the same way every time, it'll become easier to incorporate into your practice. Outcome measures should be a part of what we do no matter what kind of practice we have. And so, Dr. Rohrich, I'd love to know what you thought of this article. And also, I wanted to know what you thought about using patient-reported outcome measures for nasal obstruction as opposed to some of the more objective measurements such as rhinomanometry pre- and post-operatively.
I think it's excellent to do patient-reported outcomes because in the end, so what if your rhinometry or your nasal function airflow studies are normal and the patient's still upset or can't breathe? And that's not uncommon. I think it's long overdue in aesthetic surgery and rhinoplasty to have, to combine, your objective with your patient-reported outcomes. I mean, the reason the journal published this is because we need more and more studies like this in rhinoplasty and in cosmetic surgery to show that, it is important what the patient thinks. Probably it's the end result that really, no matter how critical we are, if the patient isn't happy, it's a failure. So this is why this study, I think, is important, and hopefully it's encouraging others to do so.
Sure. And do you use any formal outcome measures in your practice?
Well, we certainly are starting to use more patient-oriented. I don't use this outcome structure, but I use other ones that we're rolling out both in rhinoplasty and for aesthetic surgery of the face. And I think that's important to do so because it tells us, not just, we're feeling good about it, but that the patient also not only feels good about it, but also functionally in the nose can breathe better. So I think this is the beginning of, great things in aesthetic surgery and rhinoplasty. So I applaud the authors for doing this. I mean, it actually had a lot of criticisms, in the review process about this, but I think it's way overdue.
I think it's important to follow these kind of outcomes because otherwise we're not really being scientific about things. Jordan, what did you think of this article?
I really enjoyed this article. I think you and Dr. Rohrich pointed out it's important and patient-reported outcomes are being acknowledged now as being more important, and it makes sense because, like has been said, ultimately what matters is how the patient feels, and as the surgeon can judge a result and say this is a home run, but if the patient doesn't think so, then it's not. So one question I had, Dr. Rohrich, is kind of two-pronged. The first, do you think that a prospective measurement program like the one described in this article would function in a purely aesthetic, out-of-pocket rhinoplasty practice as maybe more common in the U.S. than where this paper came out of? And if not, or if maybe, how do you think it could be improved to kind of fit into that practice for people who may be thinking of implementing something like that?
I think the key points are that it can't be intrusive. It has to be quick. It has to be measurable and repeatable. And I think the patients need to have feedback. When we're doing studies, we always say, we're going to allow you to have feedback when the study's done. So to incorporate into a busy aesthetic practice like, I have and many other people have, it has to be easily done, efficient, and the patients have to see the benefit of it. And those are very important in every practice. But boy, especially in a private, busy aesthetic practice, if you slow down the process of seeing patients and the follow-up, and you won't ever get good outcome type studies. But I think this is a good beginning.
Thank you. No, that's a great point, and especially I think involving the patients, that's really a good idea, and something I'll kind of take forward. They'll definitely, I can imagine, be more invested if they feel like their input's really being incorporated. Shuja, what were your opinions of this article?
I pretty much agree with what everybody said so far, and I think you guys all hit the nail on the head with saying that you can hit a home run surgery, you can make the most patent airway, you can make the greatest looking nose, but if the patient isn't happy, it doesn't really matter. So I think that the authors, like Dr. Rohrich said, really did a solid job of looking at their patient-reported results. I think they did a very comprehensive job. I agree. I think it was really good to see that, and I think we tend to see a lot in our literature about different measurements and different scoring systems and very objective measurements. But again, if we look back and look at what we're doing for these patients and trying to improve their quality of life or improve their appearance if it's a purely aesthetic surgery, again, if they're not happy or they aren't satisfied with the results, it doesn't really matter what we've done. So I agree. I think it was a great article. One thing I found as an interesting side note is that they noted in their article that they really didn't feel like the Cottle maneuver was a useful tool, and they felt like it improves everybody's breathing, which I also have heard before and I agree with. And I think that their cotton ball test was actually a very interesting adjunct, but that's a pure side note. Looking at this from a kind of global perspective, Dr. Rohrich, you've written a lot and you're certainly an expert on rhinoplasty, and you've talked a lot about nasal analysis and assessing the patients. Do you do anything different in your assessment of patients for a functional rhinoplasty as opposed to a cosmetic rhinoplasty, or do you, like we've said, standardize things so any patient who comes in with a nasal issue that you basically do the same thing every time?
Well, I do the same thing every time, but I don't do nasal rhinometry because I've never thought that really correlated well with the functional results. So the most important thing to me is the history and the exam, and then you have to do the Cottle test with both pushing the tip of the nose up and spreading the mid-vault. And if you do them solely or independently, then they both have to be positive if you're going to have an internal nasal valve problem. I think the cotton swab is a good thing because it opens up the internal nasal valve. But, it's the exam with the patient's symptoms, and I think that is critical, and you have to restore it or maintain it. And I think doing it uniformly and then documenting it and then having, a patient-reported outcome similar to this, I would make it much simpler, too. Because patients either can breathe or they can't, or they're better or they're not. And, the most important thing in rhinoplasty is if they can breathe before surgery, you must make sure they can breathe after surgery. If they couldn't breathe before surgery and you make them breathe, that's incredible. That's as good as doing a beautiful rhinoplasty. But if you do a cosmetic rhinoplasty and take away their breathing, it's a failure. And I think that certainly wasn't emphasized here, but it's in the real world, that's the clue. As a real rhinoplasty surgeon, you have to preserve nasal function or restore it, which means you have to breathe.
I think those are all great points, and I think we had a great discussion of this article, and I think with that, we'll end the discussion. So remember to tune in to the other 2 articles we'll be discussing on this month's podcast, as well as all of our previous and future podcasts broadcasted every month. Also, don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles' authors. And once again, thank you very much, Dr. Rohrich, for joining us.
My pleasure.